like every time we do this, it's the Gulf Open and the traffic is terrible. So can you call the TPC, tell them to move it so it doesn't conflict with your. Okay. Well, hello, the people I know and to the people I don't know yet. Good to see you. Got it. So I was going to talk a little about heart valve problems, and in particular, a heart valve problem called aortic stenosis. And it's exciting stuff because we can learn about the heart, number one. And number two, this is an area where our treatments really have evolved and advanced and really have a lot more to offer to a lot more patients. Let's see. Okay. So the word stenosis means narrowing. Okay. This specifically, we're going to talk about narrowing of the aortic valve. Some people have low back pain and they have what's called spinal stenosis. We have stenosis in blocked arteries that have to be opened up. So the word stenosis just means narrowing. Okay. So the heart has 4 valves. The point of the valves is to keep the blood going in one direction. The valves open up, they let the blood in, and then they close behind. It's kind of like when your kids leave the house, you open the door for them, close it behind, don't come back in. So the right side of the heart, the right atrium and right ventricle collect the low oxygen blood from all your veins, goes through the tricuspid valve, gets pumped up into the lungs to go pick up oxygen. The blood comes around from the lungs into the pulmonary veins, full of oxygen now. Left atrium, it goes through the mitral valve and into the left ventricle. The left ventricle then pushes the blood out to your aorta and all parts of your body. So the aortic valve has to open up to let the blood out and then close properly behind it. And so the problem is that some people develop narrowing of that valve, and so the heart has to work extra hard to push the blood out, and this can have some very serious consequences. Normally the valve opens wide. There's 3 leaflets to a normal valve, although some people are born with a 2-leaflet valve. I'll talk to you about that. And it closes like that. And as the valves sometimes deteriorate, they get scarred, they get calcified, they get very stiff. So instead of being very soft and pliable, they're very rigid, and the valve doesn't open or work properly. Let me see if I can get this to work. Oh, I'm really impressed with myself. My fellow taught me how to import a video.
Don't fall off the podium.
I always make somebody nervous about that.
The same person.
So this is an echocardiogram or an ultrasound of the heart. I don't know why we call heart, I don't know why we just call it ultrasound of the heart. We call them echocardiograms. But anyway, here's the mitral valve, left ventricle. This is a normal looking aortic valve. And it opens nicely as the heart contracts. Let me see if I can switch over to the. Here's somebody with a narrowed aortic valve. You see that the valve is brighter because it has calcium on it, and it barely opens up. I don't know that I can do the stop action, but you can see there's just a very small opening there when the valve is open. And so the heart has to pump against that. So there's a couple ways that I illustrate this. Well, here's a cartoon of it. Again, a very narrowed aortic valve, left ventricle having to pump up against it. So sometimes we can think about it as a dam, right? So the left ventricle's here having to push a lot of blood through this narrowed opening, and it creates a jet. So whenever you hear a jet of water, it makes a sound. Right? So if you're in your backyard and you have your garden hose, right? As you put a nozzle on it, or you just put your finger on it and make a spray, you also hear a sound from the jet of water. Okay. Now, when I listen to somebody's heart with a stethoscope, I hear a murmur from this. So that's really, when you have somebody with this condition, that's really what's causing the murmur, is this jet of blood. There's all different murmurs. Some are very benign, some are very serious. I'm making people nervous here. Okay. But that's what's causing the murmur. That's how we often wind up diagnosing aortic stenosis. And so we have ways of measuring how severe it is. So normal valve opens like this, is about 3 square centimeters. Normally the valve is about, a little over 1 inch in diameter. And then as it gets more and more narrowed, it's sort of like having a tighter and tighter nozzle. Pressure builds up inside the hose here before you get to the nozzle, and that really stresses the heart. So what can happen? Well, some people just get kind of tired and can't do as much as they used to. Lots of people start getting short of breath when they walk around. Sometimes they could even get chest discomfort, even without having clogged arteries. And then some people start actually having congestive heart failure and fluid retention to the point where they're retaining fluid, they swell in their ankles. Difficulty laying flat means that if your lungs are full of fluid and congested, it's really hard to lay flat in bed. And people really who have big problems with this, they wind up sleeping in a chair, sleeping in a recliner, and then about a day or two later, they wind up sleeping in a hospital bed. So if you're really having trouble sleeping at night and laying flat, that's a concern. Additional concerns with this valve is that because you can't pump enough blood out, some people get dizzy and lightheaded because you're not pumping enough blood to your brain. And more severe, they can actually faint or pass out, which is a very serious sign because some people can drop dead of this. It's very unusual, but if they're starting to pass out, we don't wait very long. They get a new valve very quickly. I would ignore the bottom age thing because this is a very old diagram, but the point is that people go on with aortic stenosis for quite a while. And until it gets really severe and they start having symptoms of chest discomfort, fainting, congestive heart failure, fluid retention, they really do quite well. But once they start having symptoms, then they get into trouble. And sometimes they'll only have a lifespan of another year or two if we don't get them repaired or fixed. So the main causes are predominantly, especially in folks in their 70s and 80s, it's just what we call calcific and degenerative. It may be tied to the same things that cause clogged arteries, like high blood pressure, diabetes, high cholesterol. Some people have, when they were younger, they had rheumatic fever, and that can affect the heart valves. Although if the standard teaching is that it also affects the mitral valve. So if the mitral valve is not involved, we're not worried that this is rheumatic. And then lastly, about one out of 100 people have a bicuspid aortic valve. That means that it only has 2 leaflets instead of the normal 3. Being older is an issue. Having kidney disease sometimes causes degeneration of the valve. And then folks who have unfortunately had to go through radiation therapy for cancer can experience damage to the heart from the radiation. As the years have evolved, we've A, recognized this, and B, the radiation oncologists have gotten much better at directing the beam away from the heart. But radiation can damage the heart. It can damage the heart valves. It can weaken the heart muscle. It can cause clogged arteries. It can damage the electrical system, and people wind up with a pacemaker. So a bicuspid valve kind of looks like this. So normal valve has 3 leaflets, left coronary, right coronary, non-coronary cusp. And about 1 out of 100 people, so there's got to be somebody in this room, was born with a bicuspid valve. A lot of times this part doesn't separate, so that's how you wind up with 2 leaflets. About half or actually less than that, about 10% of the time it actually runs in families, so we do screen folks. There's something called Turner syndrome, which is a genetic disease where people look like women, but they only have 1 X chromosome instead of 2, and they have about 30% of them will have a bicuspid valve. And these bicuspid valves also sometimes are associated with aneurysms of the aorta. There's something called coarctation, which is a pinching of the aorta right about here. And we pay a lot of attention to these. A lot of times when patients have their valves replaced when they're 50s or 60s, this is usually what the cause is. Some of our patients, interestingly, don't have any symptoms from aortic stenosis. So I have a guy who's 59 years old, and he came to see me, and we figured out he needs a new heart valve. And a few weeks before he came to see me, he actually went down the Grand Canyon and came back up. How he did that with a narrowed aortic valve, I don't know. I can't do it, and I don't have a narrowed aortic valve, but not everybody fits the mold. And sometimes if we're not sure, we can do stress testing on people to see if they really are asymptomatic or not. sometimes you put people on a treadmill in the office and they can only go 2 or 3 minutes, even though they think they can walk pretty well. So that's sometimes a way of sorting it out. But there's a lot of thought that has gone into this over the years of figuring out when is the right time to replace the valve, when does it start posing a risk to patients, and when's the right time to intervene. So certainly if people are having symptoms, there are certain criteria on the echocardiogram as well, when the degree of narrowing gets really severe. But there's, as I said, been a lot of work in this field and a lot of discussion. There's a study called Early TAVR, which actually is putting in aortic valves even earlier on folks than we normally have. And we're interested to see what the findings of this are and how that'll affect our treatment. So when people have a severely narrowed aortic valve, there's no medical treatment. There's nothing that's going to make this better. I mean, we do try and manage their blood pressure, keep their cholesterol down, make sure they're not having irregular heart rhythms. But there's really nothing you can do to make the actual underlying problem better. And so for many years, the only first option is to do open heart surgery and replace the valve. And so I'll show you this. This is a tissue valve. We used to call them pig valves. They're not pig valves. This is actually made from the pericardium. The pericardium is the sac that the heart sits in. This is a pericardium from a cow that they cut around and make into these valves. And these are mechanical stainless steel valves. These people need to be on warfarin or Coumadin for their lives.
St. Jude's valve?
These are similar to St. Jude's. The one that we're using more often right now is, is this one on the left called Onyx. It's a very similar design. These have 2 leaflets that flip up and down. Here's what it looks like on X-ray when they're open and when it's closed and sealed. The Onyx valve, you can get away with a little lower dose of warfarin. Do you take warfarin?
2 things.
Okay. Well, this is like what we've been playing the past few years. We've been favoring the Onyx valves because you can get away with a little lower INR. INR is a test that we use to regulate warfarin, for those of you that are familiar with it. But the mechanical principle is all the same. Let's look back up here. And then lastly, and I'll get to this, is what's called TAVR, which is a aortic valve that we can insert through the groin without opening the chest. Because the challenge is that a lot of folks run into trouble with aortic stenosis when they get older and they're too old to really go through an open heart surgery. And, especially folks in their 80s, even 90s. I think Kissinger got one of these when he was 92. And, we've even had 100-year-olds get these valves. The rest of the parts are still working if you're going to put a valve in somebody. Mick Jagger, I think, got one of these when he was 78 and he's back on tour with the Rolling Stones. Yeah. So, but I'll go through each of these here. Again, our decision is, number one is when is the time to replace the valve? And number 2 is which valve do you pick? So when people are younger, we go through the mechanical valves. Because these have really great durability. How old's your valve?
Oh, God, not very old. I bet it's
20 years, 30 years?
20, maybe at least 20.
Okay.
Not 20.
Yeah, the durability is excellent. We have patients who've been operated on more than 30 years ago and their valve is still doing great. As I said, the downside is that you have to be on warfarin, which is a blood thinner, but the durability is excellent. The other issue is that if you put a tissue valve or a pig valve in a younger person, those will deteriorate faster than if you put it in an older person. But just getting back to the tissue valves, yeah, we used to call them pig valves, but we don't use pig, we use cow. I do want to actually just parenthetically, if you read the obituaries in the Times, there's a guy named Thomas Fogarty who just passed away about a week or 2 ago. At the age of 92, he was a genius vascular surgeon. He invented something called the Fogarty catheter, which vascular surgeons use to suck clots out of clogged arteries in the legs. But he also developed the first pig valve. I think he also had somebody told me he had a patent for a motorcycle clutch. And he has a gorgeous vineyard up in the hills in Silicon Valley where a friend of ours got married. But anyway, he was a real giant of our field. If you go look at it a little bit, it was from about a week ago. But anyway, so So this is a tissue valve, and to put this in, yes, you need open heart surgery. You need to open up the aorta, cut out the old valve, sew in the new one. This is a sewing ring here.
Now they just push it to the side.
I'm getting there. You want to give the talk? So, and these really last very, very well. I mean, most people get about 10 to 15 years of durability out of them. And so, you know, once folks hit their 60s and certainly in their 70s, we almost always use a tissue valve and not a mechanical valve. But as I said, the newest development has been what's called TAVR. So this is a valve that is inserted through the artery, usually from the artery in the groin. And as you correctly said, we don't replace the old valve, we just smush it out to the side. I'll show you a video of how that all works. But this is what it looks like. It's kind of a metal cage, 3 leaflets, also made of that cow's pericardium. And this is collapsed on a balloon, you stick it into the valve and expand it. This is a different model of it, called the core valve. This has really been around development for about 20 years, but certainly over the past 10 years, this has really accelerated. And we're using these more and more. When they first were introduced, we said, okay, they took a bunch of folks who were very poor surgical candidates, and they said, okay, well, let's, you know, half of them will get a valve and half won't, and let's see what happens. And the patients that got valves lived longer and did better. And then we moved it down. You know, when patients go through open heart surgery, there's a way of ranking what their risk is. So they started with the high risk people, and really the people with too high a risk for surgery. And then they looked at the moderate risk people, and then they looked at the low risk people. And even with low risk people, the outcomes are pretty much the same whether you do open heart surgery versus TAVR, which is through the groin. Now, if people need other things done at the same time, like if they have an aneurysm of their aorta, they have a lot of clogged arteries and they need a bypass, then they need open surgery. But if it's just the valve, then there's always a discussion about whether it should be open heart surgery versus TAVR. But the older the patients are, more frail, more other medical problems, the more that we favor TAVR procedures. So here's kind of a schematic. I'll show you a video in a sec, but here's a schematic again. So here's our aortic valve that's narrowed. Come up from the groin, bring the valve in. It's mounted on a balloon. They expand the balloon, put it in, pull everything out. It's usually about an hour procedure, actually. Patients stay overnight and go home the next morning. Although there's some people that have actually sent patients home the same day. Okay, so let me see if I can get this video to work. Help me, maybe. Here we go. All right, so this is how the TAVR procedure is done. Here's a poorly opening aortic valve. And so catheters are introduced from the artery in the groin, although people have if the arteries are too narrow down there, you could actually even go from the carotid artery or the artery in the shoulder. Put a wire across the valve. First, they thread up a balloon and just open up the valve a little bit. This is all while the heart's beating. Okay, so just open it up a little bit. Just doing a balloon on these valves doesn't work. We tried that 40 years ago. And then this is actually a pretty big catheter, by the way. This is about 5 millimeters in diameter, this blue catheter. And so here's the whole apparatus. Here's the valve itself. Bring it down into the valve. To hold it steady, they race the heart, actually. I don't know if you can see that on here. And deploy the valve, pull everything out, pull all the catheters out. There's a way to close the arteries in the groin. Let them wake up and send them back to their room and feed them some breakfast or lunch. That looks a little bit better. You sort of, don't forget all the blood that's going through your body has to go through that one opening. So Edward Sapien is probably the main valve that we use for these. As I said, there's a couple others, and there's always, new stuff in development. And this is really a very exciting part of cardiology that I've seen over the past number of decades where, we can do more and more for patients and they do better. We have more patients that we can help and take care of. But last but not least, big thank you as always to Connie and Levy for all that they do. Yes. I have time for, give me I got 10 minutes for questions.
If you. Nothing more to test. All right, first of all, thank you very much to Dr. Storch. And if you've been here all these years, you know that every year he chooses a different subject within the heart. So these are always high levels. Thank you. And I hope to never need anything close to anything on the screen here. But I know that medical advances are awesome. Anyone have a question? I'll walk around them. All right, sorry here in the faculty.
Do you routinely take LPA?
Yes.
Want to repeat it so people know?
Okay. The question was something called LPA or lipoprotein A. This has to do with it's a different type of quote unquote bad cholesterol that people can inherit, and high levels of it put people at risk for having clogged arteries, heart attacks, strokes. Actually, there's a little higher association of narrowed aortic valves in patients who have high LPA as well. There's been a lot of awareness of this particular chemical in the body for the past several years. So I check it on everybody because it helps us assess what their heart attack risk is. There are drugs that are in development that are effective at lowering LPA. And the studies are ongoing now to see whether those drugs will actually reduce the risk of people having a heart attack, dying of a heart attack, having a stroke, needing a stent. And once those studies are completed, hopefully we'll have another tool to treat people with.
IV, originally medication, right?
They're injectable medications, not intravenous. That's also in development. There's several drugs in development. We're anxiously awaiting.
I have a leaky aorta. Can it be fixed manually or can I get away with fixing the house?
You have a leaky aortic valve? Okay, so I didn't get into that too much. So the challenge with people, so let me just back up. There are some people, for a variety of reasons, where the valve doesn't seal properly. So when the valve opens, okay, but then it doesn't seal properly and blood goes, when we say a leaky valve, it means that blood that was just sent up to the aorta goes back into the left ventricle. Sorry, I'll do this with pictures. The challenge with using a TAVR is that there isn't a lot of junk and calcium for the valve to cling to. So there are some, okay, sorry. Right? So the blood goes out. Now, sometimes the valve doesn't seal, so the blood that went up leaks back into the left ventricle. It doesn't leak out of the bloodstream. Okay. The reason the TAVR works is because these valves are really kind of grungy. There's a lot of calcium in there. And so when they deploy the valve just grips in there. Because if it doesn't have anything to grip with, it's just going to fly out of there. So that's the problem if you don't have a lot of calcium around here. So there are some investigational devices. There are some devices being tested for that specific problem, but there's nothing available on the market yet.
26 years ago, I had radiation on my left breast for breast cancer. And I know you said that that could possibly be a cause of some issues. Is that something that I should mention to my cardiologist?
Yes.
I have two questions. My first one is, for us that are older, what is a good pressure, the numbers?
120 over 80.
140 over 80?
120 over 80.
120, okay. All right, right now I'm on 2 different high blood pressure medications. And they all give me really, really bad muscle pain. And again, I have to have them. And I don't know what to do about it. And also I have stage 2 kidney disease. So the tops of my feet and my ankles swell really, really bad. And my doctor just recently prescribed me diabetic for me, which I will be starting. Is there anything I can do about the muscle?
I have a little hard time answering specific questions here, and I'm not sure what's causing your muscle aches because blood pressure medicines generally don't do that. So
I was put on a statin some years ago, and now I'm reading about some controversy regarding statins. Do you feel they're imperative for good heart health?
yes, and I don't believe most of the crap that's out there that people read. I think it's wrong. But, you know, half our job now is dispelling medical misinformation from the top down.
Hi, thank you very much. I have a question. A friend of mine had an end-stage heart attack. The troponin was over 100, and they were told that she was going to die. But she lived. It really wasn't a heart attack. They couldn't do catheterization for allergy reasons. Instead, they mixed some isotopes together, and on PET scan saw that her heart was working really well. It was just an end-stage, which I guess is that an allergy that brought on the heart attack.
An NSTEMI is a minor heart attack with only a small amount of heart muscle damage. I'm sorry? No, it's not okay. That's why they were concerned about it. Normal troponin value is about 20 or less, and a really normal value is under 3.
Vera has that question, and my understanding is statins will calcify stuff that's in your artery. Does that process also affect the valve when you talk about calcification?
I mean, definitely coronary arteries probably do calcify a little bit more when people take statins, but it's not a bad thing. The valve calcifies because of inflammation and degeneration. Calcium is deposited whenever there's inflammation and scarring over. There have been some trials that have looked at giving statins to prevent the valve from narrowing, and they have not shown any positive effect. You know, it may be that it's just too late. I mean, you're already kind of closing the barn door after the horses run out, but no, we don't think the statins make this worse, but we don't have any evidence that it makes it better.
So my question is, so my son has, okay, so, high blood pressure. So my son has high blood pressure, but the bottom number coming back is they have a difficult time hearing it, whether it's manually or with the machine. What does that mean? Bottom number coming back. Yes, that.
Well, I mean, my only comment is that the bottom number, the diastolic number, which is the blood pressure when the heart's relaxing, sometimes is a little harder to read. It's very easy to pick up the systolic either by listening or even by feeling your pulse. But the diastolic sometimes it is just a little harder to find out where that cutoff is. And particularly with the home blood pressure machines, I mean, they sometimes have a harder time than we do, you know, using a stethoscope in the office. Sometimes it's just not easy to hear it. Everybody's a little different.
Does diet, especially eating red meat and whole fats, have anything to do with the heart and lead towards, you know, the stenosis?
So the aortic stenosis that I spoke about is different than the stenosis of clogged arteries. So yes, we want people to stay away from saturated fats and red meat to help prevent plaque buildup and cholesterol buildup in the arteries of the heart, but it doesn't have any definitive effect on the heart valve.
Does exercise exacerbate the possibility of a heart attack if you're calcification, or how does exercise affect this?
It's good for them. It's good. Exercise is fine. You know, I mean, there's always, you know, especially with the snowstorm now, there's always like the concept of like somebody shoveling snow and having a heart attack. But, you know, if you look at like what hour of the week people are most likely to have a heart attack, it's 5 in the morning on Monday morning. You know, I mean, most heart attacks happen when people are sitting doing nothing.
What's bundle branch blockage in regards to this?
Completely different. It's one of the electrical circuits doesn't fire.
So it's not the aortic.
That'll be a topic for another year.
Okay. All right, if you,
All
I
right.
think I got everyone. If you have a question that wants an answer, and it's not a personal question, I know that I can email Dr. Storch.
Sure.
If it's personal health, you gotta see the doctor, maybe him. And if you like this card, we do have some of his cards on the table on the way out. There are a number of his patients here. You can ask them if they want to share, but they're still his patients. So that is always a great benefit. In Judaism, they say they should have a rofe yadid, a friend, a doctor who is a friend, because they truly care about you. And I know that I can speak on the rofe yadid part here. But again, thank you so much, Dr. Storch.
You want both of it, you have all the time.
That's all.
I really don't have to be able to tell them, like,
Again, thank you very much, and we hope to see you at some of the upcoming events, including Super Bowl and everything else. Thank you.